Good afternoon. My name is Dr. Randhawa. I'm the founder and chief executive officer of the Southern California Food Allergy Institute. I'd like to welcome you and thank you for joining us today for one of our live stream events. We've had a very long and unusual last year and a half where many children have not been able to attend school in person. And for those who have food allergies and food anaphylaxis, this now in the next few weeks is the first time they'll be back in school in person. And now all of a sudden it becomes real again. So we want to spend the next 20 minutes to 30 minutes to discuss what to do next as your kids kind of go back to school, really kind of understanding what you can do in the school framework to make sure that your children are protected to the best possible level across the board. We will also spend a few minutes talking about COVID vaccines, particularly in kids with food allergies, since that's going to become an upcoming topic. And then, of course, we want to talk to you guys directly and answer any questions you may have after that. I've been taking care of kids with food allergies and food anaphylaxis for the better part of 2 decades. This is something that I've learned over time has changed, and I hope it continues to only get better. I'd say the most important thing to recognize is that you're not alone. Remember that you're looking at the better part of 8 million plus children in this country who have food anaphylaxis. And so when we're in a position to try to go back to school, and unfortunately now you're dealing with school systems that are really heavily focused on COVID, therefore their attention may not be towards children who actually have food allergies. You're gonna have to take some extra steps to bring folks together and advocate and endorse on behalf of your children. Best to do it as a group. That's really, really key. So if you look at food allergies in general, remember that, again, they're extremely common. This is something that is typically not announced in a typical classroom setting. So it's really important that you work as a group. It's not something to necessarily keep silent. I think most teachers, especially in the kindergarten to the early elementary years, are in a position where they're often very willing to discuss this. I think school principals and heads of school are often very good about talking about this condition right up front. The most important thing to do when you're actually talking to schools or administrators is to say, what is your policy? Generally speaking, every public school, every private school in the nation has an actual policy on food allergies. Some may actually have a policy that states they won't do anything specifically different for kids with food allergies, but many actually have a significant number of restrictions. So it's important to get that information out the door right at the beginning. Then the next step, which you want to do, is talk to other family members, if possible. Anybody else who has food allergies. If you're looking at a typical school classroom setting of 20 to 30 students, there's a very good likelihood there's at least 2 children in that classroom that actually have food anaphylaxis. They might have different food allergies. Some might be anaphylactic to milk, some might be anaphylactic to peanuts, but that's the discussion that has to come into play. And as difficult as it is, the reality is that you cannot necessarily create a completely safe environment, meaning you cannot restrict every single food type. It's important to remember that we have the big 8 foods that we always talk about: milk, eggs, soy, wheat, tree nuts, peanuts, fish, shellfish. Reality is we can't control all of those factors in place. So there's a lot of things we want to talk about here in the next few minutes that are specifically focused on mitigating and reducing risk. But I can't say that enough. Work as a group. I personally have 3 children. None of my kids have food allergies, but I have worked very hard in different school systems to endorse and advocate on behalf of kids with food allergies. I found it to be a meaningful level of work, and it's something that can be done. So it's something to do best as a group. Before school starts, the first thing to do is reassess your case. You always want to know, what is your level of risk? If your child had a reaction to milk when they were 1 year old, they're now 6 years old, you'll want to know what has changed. Easiest thing to do is pay a visit to your doctor, pay a visit to your pediatrician, pay a visit to your local allergist, and really try to understand what has actually technically changed. In some cases, food allergies get worse over time, unfortunately. And so kids who may have had very low numbers, 1 or 2 years of age, now may have much, much higher numbers that are significantly putting them at greater risk. And sometimes the opposite occurs, where kids don't, again, necessarily outgrow allergies, but their immune system can adapt. And indeed, some kids can not have severe reactions. And indeed, sometimes if the risk is exceedingly low, those children can be food challenged safely in an allergist's office. So before you ever start school and go down this road again, it's really important that you recognize you should go pay a visit to your doctor. The main thing to do when you have a discussion with your physician is to make sure that they are in a position where they're going to help support you. Are they going to fill out forms for you? Are they going to go talk to the school on your behalf? Are they going to prescribe needed medications in a timely manner? These are all really important things. You want to kind of reestablish that relationship, especially given what's happening with the absence of school in the last year plus. And remember that, again, the majority of folks right now are just focused on the pandemic. So if you look at any school situation right now, all they're trying to do is figure out how to isolate, pod, rotate kids in. And all these schools now are in the next 4 weeks going back full force all across the country. So their ability to prioritize your children who have food anaphylaxis is going to be limited. As much as I'd say speaking louder will change that, it probably won't. So it's going to be your due diligence to organize all the paperwork, get there early, get there ahead of time, talk to the teachers, and then you'll have a much better experience. I think it's really important to talk about what can happen on a day-by-day basis with your child directly, as well as with your teacher. So children at a very young age can make some very good decisions, but they need to be aware. And they should understand that why they are in a position where they have to limit certain activities or limit certain exposures is due not just for fear, but it's really for their own safety. And when you advocate based on safety, it's a much more easy way to have a discussion rather than fear. Talking to teachers is really key. You want to have teachers understand that your child may have, for example, 3 or 4 snacks during the daytime. How is that going to be laid out? And having a situation set up where your teacher is actually on your side means giving them a lot of information, giving them an actual schedule. Here's my child's meal plan for Monday. Here's my child's meal plan for Tuesday, et cetera, for the rest of the week. The more they know, the more they can be prepared, things get a little bit better. If you look at where most reactions occurred in a school setting, most reactions actually occur inside the classroom. The very few studies that have been done on that is the case. Why is that? Because inside the classroom is when food that is not on a schedule is brought in. That could be another child's birthday. It might be the teacher's birthday or some other celebration. They bring in external food. They're not sure what that food is, and a child who's allergic unfortunately gets their hands on it, and now something happens. It is not so common to see an allergic reaction from another child bringing a certain food in, because if it's done properly, things are spaced effectively, things are actually organized effectively, and things are cleaned effectively between food exposure and getting back to normal activities. So it's important to have a discussion with your teacher, depending on whether or not this is an elementary student, a middle school student. Those kinds of discussions have to be had. For older children, I think it's one of the most important things to decide whether or not your child is able to carry their own epi. Can they carry their EpiPen? Are they knowledgeable enough to use their EpiPen? And then what's the school's policy on making that actually work? For some odd reason, many schools are very strict on this. I think they've had some bad experiences where an EPI's been deployed erratically, and that can cause injury. And so it's kind of this balancing act. But again, if your physician's on your side, most of the time they can do an assessment and they can actually authorize that your child can take that EpiPen and actually take it to school on their own for their safety. It's also important to really determine what level of school nursing support is available at your school at any given time, because reactions can happen. They can happen, technically anytime during the school day. Interestingly enough, at least in certain public school systems in the country, many of them don't have a school nurse assigned to them all the time. In fact, you might only have a school nurse assigned to your school several hours of a given day per week. And that's all that's technically required from a federal and state level. So if that's the case, then obviously the next step is you need to figure out who's the number 2 person. Is it going to be the head of school? Is it going to be the teacher? And I think that's some of those key discussions that need to be had. Another aspect that should be considered is, where do the medications actually stay? If you have all medications, epinephrine and so forth, stored in one area, one office, what happens if a child has a reaction somewhere else? I'll give you a quick note about that. We had a child probably about 9 or 10 years ago where the school was located on the top of this small hill, and he had an allergic reaction in a field which was at the bottom of the hill. And of course, after he had his reaction, he had to get his EpiPen, which was located in the office, and he had to run and walk up a hill to get there. That significantly worsened his reaction. Thank goodness he did fine. But the point is that type of situation should not have occurred. And I think, again, a lot of this is really getting back to how well prepared are you in addressing this with the school, and how well is the school really prepared to handle these types of situations. So overall, this type of approach is key. One last point towards field trips. Again, field trips, I'm not totally sure they're going to make a comeback this year given the pandemic, but should they actually make a comeback, that is usually the number 2 area where you see reactions when it comes to allergic problems. And that's, again, because it's outside of the normal situation. So if you're going to a museum or going to some other amusement park, those types of areas become a concern. Again, I strongly endorse individuals to go be part of their classrooms. Parents, at least one parent who is food allergic aware should be present on those types of trips. I think that's generally the case, but again, it requires quite a bit of discussion to make sure that this actually happens properly. This slide really I'd say summarizes what we should be doing for all of our patients with all the key players who are involved in the case. First and foremost, it's your child. And, again, older children, it's a different ballgame. They're junior, senior in high school. They generally have enough knowledge base to say, yeah, I just don't eat that. I'm allergic to peanuts. I'm allergic to cashews. I just stay away from those things. But it's the kids who typically are transitioning. They're going from elementary school to middle school, from middle school to high school. Those kids have less technical, I'd say, confidence to speak up about their medical condition. And it's so important. We see that all the time. Most reactions tend to occur during these times of transition. Important to sit your child down and say, listen, this is part of your medical care, part of your medical diagnosis. It doesn't have to be something that's amplified per se, but at the same time, it's something that's very important to designate and talk about. Because one thing is to not say you have this medical condition. Another thing is to say, you don't have the problem and end up having a massive reaction where an ambulance comes to school, and now you're stuck in a totally different situation where you got all that attention that you were trying to avoid in the first place. So no sharing of food, that's key. Lots of hand washing, that's also key. Again, a lot of schools now are pretty good about this, at least from a COVID standpoint. You can count that as a win because hand washing has gone way up, and disinfecting and cleaning up areas has also gone way up, and that's a good thing. When it comes to epi, again, as I mentioned earlier, either you can carry epinephrine, and I've had children as young as 8 or 9 years of age actually carry their own epi. I think they have to demonstrate use. They have to demonstrate the knowledge base. Remember that there's different types of EpiPens out there. So they have to really show you and perhaps a medical provider that they're actually able to utilize this EpiPen effectively. And if not, then where is it going to live? Is that EpiPen going to be with the teacher? Is it going to be with the main office at school? Those kind of questions need to be addressed. It's important to talk to the teacher and have a real frank conversation. I deal with patients who have all kinds of medical conditions. I have patients who have seizure disorders. I have patients who have metabolic disorders. These teachers are well prepared to deal with all kinds of medical conditions. And if they have a knowledge gap or if they need additional help, it is really imperative that the school and the school district come in there and help fill that position of knowledge so that your child is safe. So don't feel like you're any different than the individuals who have those kinds of medical conditions. There's no difference. So having that frank conversation about their level of knowledge, their comfort in dealing with, their comfort level in dealing with this medical problem is going to be very, very key. It's also important that they hold true to the organization of the classroom and hold true to the organization that keeps the classroom safe. When it comes to the actual school itself, as I mentioned earlier, I think it's important you understand the school policy towards food allergies, and they should post it in an obvious way. If there's a school cafeteria, it should be posted. If they're serving food that's cooked on site, it should be posted in the back area of food preparation. If food is being brought in from an external facility, that external facility is now held really accountable to making sure this food is safe. So it is important that the school has an open and accountable model towards how they deal with food anaphylaxis. Lastly, which we'll talk about in a little more detail in a second, is the availability of 504 plans. Now, if you're deep enough in the world of food anaphylaxis, 504 plans are nothing new, but they can be dramatically different region to region across the US. They can even be different within different school systems. So we'll talk about that with a little more detail. I'm not sure every child technically needs a 504 plan if everything else on this slide is actually working for them. But when it's not, or they have a particularly complex case, that's when you sometimes have to go to a 504 plan. It's important that you talk to your allergist. Again, I think getting an honest assessment of risk is key. Just being told that, oh, well, you're mildly allergic, or I don't know, you have a degree of allergy is not a satisfactory answer. You want to get a real good idea of what is the level of risk? How much exposure is going to cause my child to have a reaction? How careful should I be? I think one of the most common questions I get asked is my child who has anaphylaxis, quote, airborne? And what I tell folks is there is a level and a level of case that exists that makes someone, quote, airborne allergic. And we know what those values and those systems are. And indeed, other specialists also are aware of that. They should give that level of detail. So either that level of risk is announced or that level of risk is mitigated. And lastly, family. I think it's important not only to talk to your own extended family, grandparents, and so forth, make sure everyone's on the same page when it comes to food anaphylaxis. It's important to talk to other family members. Now you will start to see soccer games and club games and now get-togethers after school start to come back. How will those be handled? Are the parents aware? Do they know how to handle those particular cases? I will tell you that I see on a regular basis that most people are very much afraid. When you start saying, well, yes, I'd like to have my son over at your house, thank you very much, but by the way, here's his EpiPen and here's his medications in case he has a reaction, all of a sudden their level of or degree of willingness to do that can change. And it doesn't have to be that way. A lot of it comes down to their knowledge and their understanding of what food anaphylaxis is, and really the knowledge of your child and you as a family to make sure that communication level is brought to the top level. So when it comes to starting to prepare for the school year, step one is having a good anaphylaxis plan. For those of you who are in our program here, you know that we give you a very, very detailed anaphylaxis plan. My advice for any patient who are in the tolerance induction program is that the plan we give you is likely far too complex for a typical school system. It's better you just use a simple plan. Or imagine if you're a school teacher and you're managing 20 plus students and you are dealing with an allergic reaction. The last thing you want them to do is delay actual treatment because they're trying to figure out, well, what does this plan say? I'm not sure exactly what to do next. It's better that they just, give the EpiPen. So in most cases, these types of plans exist. They have to have several pieces of key information. Number one, identify the allergy. So for example, if your child's anaphylactic to cashews and pistachios, that should be listed there. And hence, if they go out on the playground, they come back and they have a rash that looks like a hive, the first question the teacher should do is pick up that form and say, oh, okay, this child's allergic to cashews, pistachios, and there was clearly no food on the ground. So I can take a step back and have time to analyze. They shouldn't have to pull out an EpiPen for something of that nature. The second thing is contact information. They need to have immediate contact information to the parents. They need to be able to know what to do in those cases to convey information. Number three, it has to have the medications that are necessary to reverse the reaction. And again, in most cases, that's immediately deploy Epi, and if possible, have different types of antihistamines available. And then of course, number four, have immediate access to emergency care. So this can be as simple as that, and that's what I recommend. Simplicity is key when you're dealing with lots of children. And then this needs to be readily available in the classroom. And in fact, what I often will ask teachers, I recently gave a talk to hundreds of school nurses here in the local LA and Orange counties. And it was interesting that I asked them how they are organized when they deal with all of their cases that they're of kids who have anaphylaxis. And I was surprised by the variety of options that they use. And I said, well, in case it's a child in a classroom, are they going to call you as a school nurse, or how does that typically work? And what I encourage them to do is whatever they're doing centrally in the school nurse side, they should actually have that in the classroom itself with easy accessibility. And again, the best example I gave them is just like any other medical condition, those notes, that information should be in the teacher's desk. It should be right there so it's easily accessible in a binder and they know immediately what to do next. So this type of conversation is important. It cannot be as simple as saying, hey, here's a plan, good luck to you, walk them through it. It's going to be really, really key. When it comes to 504 plans, let's walk through this a little bit more clearly. Part of the reason why you get some pushback on 504 plans is because the actual school is now put into a legal contract with you. And if it's not listed quite correctly, I'll give you an example. If you are requesting that somebody monitors your child during recess because you're afraid that potentially cross-contamination can get on a basketball or something of that nature, then they are legally held to that standard. They actually have to have somebody show up and actually monitor your child and monitor that play area. That can be a difficult situation from budgets. It can be a difficult situation across board. So there are other things that unfortunately allow school systems to sometimes say no to certain 504 plans. But do your homework on what you think your school will allow. Talk to other parents at your school who've actually had 504 plans successfully go through. And I'd say have a reasonable approach to see what is a fair middle ground to actually have your child get to that state of safety. A finalized plan actually has to be signed off by not only the school, it has to be signed off by yourself, and typically has to be signed off by a medical provider. The medical provider is typically an allergist. And again, some allergists are not terribly keen on using 504 plans. It can be a little bit time consuming and so forth, but I do encourage everyone, if you really feel, especially if your child is very young and has 8 or 9 classes of different anaphylactic allergens, it's probably a good idea to pursue a 504 plan. If you have an older child who's in high school and they're well versed in how to take care of themselves, a 504 plan certainly may not be necessary. When it comes to EpiPens, again, this is life-saving, period. I wish there was a way to shrink the size of an EpiPen so it's easy to carry. I wish there was a way to make sure that it had a longer shelf life, it was more temperature stable, but unfortunately, this is what we're stuck with. Not that long ago, we were stuck in a situation where the supply chain actually started to hit EpiPens. So getting access to EpiPens, being able to have 2 EpiPens, which is ideally what you need, not just one, that becomes all the more difficult. So how do you have a school be prepared in those situations? Again, a lot of it is put it on your calendar, remind them, call them every couple months and say, I'd just like to do a check-in. Do you have my child's anaphylaxis plan? Do you have their EpiPens in stock? What is their expiration date? And again, as much as we like to believe that the school should be doing that as effectively as they should, the onus fundamentally is on us as parents to make sure that we cover our children to the maximum level of safety. A couple points on EpiPens. Remember that EpiPens need to be trained. Kids need to feel very comfortable using them. Certainly if they're over the age of 12 or 13, I do believe children should know how to use an Epi on themselves. Remember that EpiPens can be deployed directly through clothes. You don't need to remove clothes to do it. So if there's ever a situation where you're worried about it, just deploy it through the actual cloth itself. There's actually been some engineering studies done on this. You can deploy an EpiPen through very thick, jeans. So jeans themselves, which are the hardest to push through, does really well. Lastly, if an EpiPen is expired or the EpiPen's been in heat, the chance of it actually not working is very low. Epi itself, adrenaline, actually has a shelf life that's probably at least a year out after expiration dates. I'm not saying keep those and use those, but in case you're ever stuck where you find out last minute that that's all you have, better use it and call for help rather than get into a position where that's not the case. I think it's really important to talk about safe snacks. Again, I'm not going to spend too much time on this, but it's important that your child feels enabled. They need to have access to snacks that are going to be safe for them, that they can actually take to school, so they feel like they're part of what is the general community and the general feel of what is going to school these days. There are hundreds of companies out there now that are excellent at producing very safe products. I encourage you to get online. There's a handful of app-based programs out there that list these very effectively. One thing I like about the ones that are absolutely focused on food allergies is that you can generally trust that they put in all the effort in from an FDA standpoint to make sure that their labeling is accurate. For those in our audience who are not tolerance induction program patients, I have to at least mention this. The kids who are in our program, in the tolerance induction program, are not quite in the same situation as kids who are not in our program. So kids who are in treatment, kids who are in remission, when they go back to school, there's some slight caveats to this, and I'll just kind of loosely mention that, which I think is important. Our program, again, just for those who don't, who are not aware, tolerance induction program is really has been a program that is growing very quickly. As the founder of that program, it operates based on this model. And this is a big data, big movement model that basically looks at a singular immune system of a child, compares it up against 100 trillion points of data, and is able to actually apply that form of mathematics towards your child. And we can actually pre-treat, condition, induce tolerance, and induce remission. The beauty of that is by the time they're done, they can actually eat like a non-allergic child, eating whatever they want, whenever they want, without restrictions. This form of treatment is great. It's something that we've been working on for many years and continue to improve on a regular basis. But at the same time, this is something that when your child's in the tolerance reduction program, how do you communicate that to your school? Number one best thing is refer them to our website, get them familiar with it. I'm proud to say that with over 12,000 plus patients in the program, we have a pretty sprawling outreach. People know who we are. The second thing we're able to do is we're able to talk to the school for you. We have a large number of providers, medical doctors, and even community outreach leaders who can actually go have conversations with school. As I just mentioned, I spoke to LA and Orange County school nursing associations because they asked to know more about this program. We're happy to do that for any school system across the nation, frankly, so that this information gets out there. As your child goes through the tolerance reduction program, depending on where they are, as you all know who are in the program, we will determine a level of cross-contamination clearance where you can actually just take it easy and your child doesn't have to worry about those foods. Once they're in remission, you're good to go. There's nothing to worry about. We still ask that Epipens are available and that they still have an anaphylaxis plan, at least even into the first years of remission. That's very important. What we do here is we supply you with a medical letter, basically a letter stating that your child has finished and completed the tolerance reduction program, and this is their next steps ahead. So again, however we can help you with that, we are more than happy to do so. But this is something that's very unique to our patients in our program, again, over 12,000 strong. I want to briefly mention COVID. We actually published this work where we studied food anaphylaxis patients and studied their ability to produce antibodies, their ability to handle latent infection of COVID. And the general answer is the same. Kids with food anaphylaxis, kids with general allergic disease are at very low risk to contract COVID. And indeed, if they happen to get COVID, they seem to get over it very, very well, very easily. So that's good news. The second aspect is vaccinations are key. And vaccinations in food allergic children and adults were initially a very slight concern. Now, hundreds of millions of patients later, we know that it's minimal to no concern. We actually here at our facility have been administering the COVID vaccines, both the main mRNA forms of that, and we have been monitoring our food anaphylaxis patients here very closely. And happy to say, after 100 plus of those patients getting dosed, we've not seen any significant reactions from an allergic standpoint or really any other standpoint from that matter. So again, I encourage you to keep an open mind towards this as your children go back to school. Do not let the overlap of food anaphylaxis and the vaccine dissuade you from getting the right type of resource from your kids. I'll make one last point here about COVID. There are only 3 major groups of individuals right now as we hear about this Delta variant and the current number of cases that are high. Either you're unvaccinated and have never been infected, you are unvaccinated and you've previously been infected, or you're vaccinated. There's only 3 groups. And my main point on this slide is this. Look at the infectivity rate if you happen to get sick, depending on which group you're in. And exponential growth is the biggest problem. If you're in an area that has a lot of individuals that are not vaccinated and have never been infected, that's where you're seeing the huge surge numbers. If you're in areas that have a lot of vaccinated folks, even if you happen to get sick, again, the symptoms are mild, if even noticeable, and look at the transmission rate. It's really imperative if we're ever going to get past this pandemic that we get people vaccinated. Again, more vaccines are going to be available here in the next number of months, but I would not wait a significant period of time. It is time to get people vaccinated so we can get past this as a whole. Boosters are definitely going to be coming. Non-mRNA vaccines are also coming, but the bottom line is we have to get past this immediate point right now where we're still having infectivity rates that are high amongst the unvaccinated individuals. So hopefully that was enough on COVID. I know I've done a lot of informational talks on COVID in the past. I generally say one little point about that. At least in California, I could tell you probably the next 3 to 4 weeks, we'll see our little mini surge go down. The rest of the nation in highly unvaccinated areas may take an additional 2 to 3 weeks. I encourage you to look at our last video on COVID back in April. It's actually done a pretty good job at describing the world of how the vaccines are going to lay out and how we've done overall moving into the fall. So hopefully all goes well, and hopefully all goes well as all your kids go back to school. That's going to be the most important thing. Getting kids back to school is key. I've been fortunate that my children were able to get back to school all of last year. And I did certainly see a nice difference, and even with some restrictions, it was still a very positive thing for them. So with that said, we're going to be ready to take some questions from our audience.
Hi, my name's Jenny. I am from La Crescenta, and I have actually 2 kids in the program who are now on their tolerance visits. So I'm kind of just wondering, what kind of wording do I want to put on their school forms? And they're still very close to remission. Probably by the end of the year, beginning of January next year, they'll be done. I'm just curious. So in the meantime, though, what should I put?
Well, first off, congratulations. That's good news. The question is really about wherein you are in different stages of the program. What should you put on your school forms to allow your child to go back to school so the knowledge is the same on our side as well as the schools? So the most important thing to write down is that your child is in a form of immunotherapy. Your child is actually going through treatment. That's number one. So, again, that can be used for other medical diseases, but that's number one. Number two, it's important that you ask our system, our providers, to provide you with what are considered food proteins that are safe and what are food proteins that are still in a form of treatment. Any food protein that is safe, that is essentially cleared, can be listed, and you can actually tell the school these foods are not a concern at all and can be exposed and without risk. And then these foods are still at a level of risk. And what that means is until you're in remission. So let's say, for example, your child has peanut in the tolerance visits. We would still want to limit the amount of peanut exposure at school. You're handling your treatment program at home and here in our center. Once you're in remission, that all changes, because once you're in remission, you can actually state on there the child is in clinical remission and they can be around peanuts. They can actually ingest peanut products, not a concern. We still ask them to have Epi available at school, again, because legally, while we define remission as such, we cannot control human behavior. So in case a child slides out of remission, they should at least have that availability. As I've stated many times in the past, that has not been a concern, but we are still in a position where we want to do what's safest for our children.
Hi, my name is Catherine Egger. I'm from Huntington Beach, California. I have a 5-year-old son in the program. He's been in TIP for about 2 years now, and he's coming up to his tolerance visit 1 at the end of this month. So my question is a little similar. He's starting kindergarten this year, and it will be after his tolerance visit 1. What do you recommend that I tell the school and his teachers, since he's already eating all of his allergens, but he's not quite in remission? His school is not free, but they have a table for kids to sit who have allergies, but I don't think that's necessary at this point, but I'm not sure how to go about it.
Thank you. That's a great question. Again, congratulations. That's great news. When kids at tolerance visit 1, I would say 9 out of 10 times, they're really only treating one food. So whatever is your primary food that's under the treatment category, that food should still be limited exposure-wise at school. So let me give you an example. If it's peanuts, there's going to be an amount of peanut exposure that's occurring during treatment phase, typically in the evening on a daily basis, 6 out of 7 days during tolerance visit 1. At that stage, there's one day of the week where you can eat whatever you want. You can go way above, you can go way below. So you know that there's a big range there. So in a case like that, I would say, if there's other kids eating peanut butter and jelly sandwiches, not a problem. Would I have them give your child a peanut butter jelly sandwich to eat? No, we still want to limit that. So again, cross-contamination risk has already been completed, nothing to worry about on that side. That could be documented for the school from a liability standpoint, and we're happy to, again, to endorse on behalf of your children, make sure that happens correctly. But getting that kind of documentation is going to be really key. Once your child hits remission, though, again, it's all fine. They can eat whatever they want. They can eat other products that have peanuts, as an example, and so forth.
Hi, I'm Lindsay Thomas from San Diego. I have a 4-year-old in the program, and she will be starting preschool for the first time she will be out of my care in her life. So I guess my question, you touched on some of my fears already, but she's anaphylactic to milk and egg, and they do have milk for their snack program. So I guess my question is ingestion versus contact. With COVID, luckily they will be doing hand washing and wiping. But I guess if she were to have a reaction that's just contact, is that something that would warrant an epi, or what is the protocol that I should discuss with the school in regards to that? And then I do have a second follow-up in regards to the EpiPen and where it should be stored when she's playing outside, since she's so little.
Great question. Thank you for trusting your child in our program. She will also get to food freedom. In the meantime, again, school's important, and we want to make sure that every child, when they go to school, is safe. I think I'll answer your question a couple different ways. We should be able to tell you if your child is in a position where, a droplet or, an air level of exposure is serious. We're happy to answer that question directly for your case. Again, most kids are not in that situation. So then the second question is, how much milk does it take to trigger anaphylaxis? And again, there's not a lot of data out there for that. We have a lot of data collected over all these years as we've seen what elicits, what are eliciting doses essentially, based on kids' previous reactions before they ever started this program. And so typically when it comes to milk, you would have to ingest, I'm assuming, a young child about 30 to 40 pounds, they would have to ingest around half a teaspoon of uncooked cow's milk to really get into a risky situation. So it does take a lot to get there. However, to your point, if your child is touching milk and say rubs their eye will swell significantly. If it gets in their nose, it could be problematic. And I think the best thing to do is in those situations, have a discussion with the teacher and say, what is it that you are able to do in the classroom versus what needs to be present elsewhere? And if they're unable to give you a satisfactory answer, that's a good place to go for a 504 plan. Having somebody who can actually be present, pay closer attention, that will alleviate a lot of your concerns. So the answer to your question in succinct way is get a 504 plan, and we'd be happy to fill that out for you.
Hi. First of all, thank you for all you do. I'm Jenny. I'm the mom of a 3-year-old boy. He's about 18 months into the program, and we've finally gotten to a place where my anxiety as a food allergy mom is low enough to send him to preschool. So he'll be starting in the fall. He is, going through the program, has made a ton of progress. He's on, pretty far into dairy, egg, and peanut, but just wanted your perspective on the necessity of an allergy-free table. And is there a point in the program that, maybe that's not a necessity anymore and before graduation, but, they no longer need to sit by themselves or at a dedicated table?
Yeah, that's a great question. And I think it's, I'd say a lot of that question depends on a child's unique allergy profile. What are they anaphylactic to? I would say as a whole, if you get to tolerance visit 1, you are in a pretty good position where those tables can go by the wayside. It would take quite a bit to be problematic. So tolerance visit 1's, a slam dunk in that sense. However, as you progress through the program, proteins are cleared from a cross-contamination standpoint. And our definition of cross-contamination is based on data, right? So we're looking again at eliciting dose data. And again, this is, trillions of data points, and we take this obviously very seriously. So when we say somebody's cross-contamination clear, that has a lot of meaning to it. And so in the world of dairy, we have those numbers. In the world of egg proteins, we have those numbers. Tree nuts, we have those numbers, peanuts, seeds, et cetera. So, we have to be in a position where once a child's going through the program and they actually have crossed those numbers, we should have the confidence to let you as a parent make a decision as to what cross-contamination means for you. We know what it means for us. Does it mean for you that your child can sit at a table with other kids who are eating certain foods? That's a discussion we can have. I generally tend to be quite confident in that because, I've been doing this a long time. And so we know when kids are able to get past cross-contamination, they're able to be at allergy-free tables. And to be frank, we see that they end up getting exposed to things that are high risk, even though they're not totally done with, say, dairy, for example. But that's how the program works. You know, you go through enough conditioning, you go through enough tolerance induction, you are in a markedly safer spot. So what I tell anybody who goes through this program, as you get through different phases of treatment, your child is getting better. And we prove it at a molecular basis every time we repeat testing. And as you get further through the program, you know that your child's getting safer and safer.
Hi, my name is Anne. I'm from France, but I live in Los Angeles. I have two kids in the program, a 4-year-old and a 7-year-old. They're both pretty far from remission though. My question for you is not necessarily related to the program itself, but in my experience as food allergy parents, we are often faced with some kind of disbelief or even indifference when it comes to explaining the severity of the allergies of our kids. And it can be the case with other parents at school or sometimes with the school staff itself. And so I would like to know if you have like any advice to get people to actually acknowledge the severity of the allergies without sounding like the crazy mom or the overprotective mom or the paranoid mom.
No, thank you for that comment. I will tell you, when I first started this program 15 years ago, I didn't know a lot about this side of food allergy, food anaphylaxis. And I found that parents would do, especially moms to be frank, would go to any length to make sure their child stayed safe. And even if that made other systems have to adapt, they would get it done. And they often paid a price for that, which was not fair, in my opinion. So what I found over time, though, is that systems are built in a way where they generally want to help kids. I mean, that's a pretty fair statement. But at the same time, they don't quite know what is a reasonable ask or reasonable expectation. Because, there are cases where a child may have multiple food allergens and they want the classroom completely eliminated of those things. And, in certain settings, that's simply not going to be possible. And often I've seen those kids end up getting homeschooled, for a period of time. Indeed, that's why I built this program, because I knew that there was no way to get to a point where the world or the community or a classroom is going to be totally allergen free. And I don't have any degree of confidence that we can design, modified forms of food that are going to be safe. So what we can do is use our system and the evolutionary protein methods and the immune system methods to actually retrain the immune system to get to a place of remission. But to your point, I think it's really important that you work as a group. Now, we've done this a couple times where we have pro bono advocacy groups as well as pro bono attorneys where we have some very difficult school systems that don't want to budge. We're happy to hook you up with those folks. It's really important to have some of those resources available. But again, I would advise not going in with a stick. I advise going in as a group and really try to request some change and ask things to occur in a series of steps. And unfortunately or fortunately, if possible, sometimes the best thing to do is to have one parent present as a volunteer at the school, at least for a period of time as your child gets more and more comfortable, because that's the best level of safety there, right? No one's going to take care of your child better than you. So I hope that answers your question.
Hi, this is Darlene and Parker Carenza. We're from Miami, and we first wanted to take the opportunity to just thank you for this incredible program. Parker is a TIP patient currently going into 4th grade. And we just wanted to know, what should we provide the school in terms of medications to have on hand? So of course we know Epipens, but we carry the scenario kit everywhere. So as a TIP patient, is there anything else we should provide the school in terms of information and medications?
Thank you. Good seeing you, Parker. I think it's important that if your school is in a position where they're highly interested in this program, and I've had that experience. We've had a number of schools over the years actually request our scenario plans for their patients. They seem that they are very much vested in following those plans. Interestingly, I've had emergency room doctors love those plans. Again, they should be based on weight and to some degree, sometimes endotype and things of that nature, but largely they cover all those different bases. And if the school's interested, I recommend giving it to them. But I would say it's the minority of cases that are willing to actually do it. For the cases where they're not so enthusiastic, they definitely need epi. They definitely need Benadryl, and I strongly recommend a liquid-based steroid. Having all of those available, having them available and actually dosed early in a reaction gives you your best singular chance of a positive outcome. So, I've had patients, obviously I'm a pulmonologist, so I have patients with various types of lung disease. They're willing to have different types of drugs available for them in case they have an acute for severe asthmatics or severe lung disease. Having those types of drugs available, they are willing to do that. So it's something that we do encourage, having at least a few of those drugs available: epi, and a good antihistamine, and a liquid-based steroid.
Hi, Dr. Randhawa. My name is Alana. We are from Dallas, Texas. Our son has been in the program for a little over 2 years. I have a question regarding the food allergy and anaphylaxis emergency care plan form. Our son is anaphylactic to walnut and hazelnut, but already tolerant to other tree nuts thanks to the program. Would you recommend us be specific on the form, like walnut and hazelnut, or should we put tree nuts even though he's already tolerant to macadamia nuts? The second question is, my son passed hen egg white last year and not CAP. So should it be still listed as extreme reaction or anaphylactic? Thank you so much.
Thank you. To answer your question specifically, again, it's best to actually get that information directly from our provider line as well, but I'm happy to answer it for you. Foods who are, so as you know, when you go through the program, labs are repeated, especially children like your son who have been in the program for a bit. We're able to take tolerance-based foods and reduce frequency. And by definition, remember that remission means that every single allergen, but most often their most high-risk allergen, which on their snapshot is listed on the left and the top, those have to be at 7-day cycles. So everything's 7 days. You don't have to worry about anything. You don't have to label that at school. Just you basically want to say they have been treated, they're in a state of remission, and that is at that time. However, for right now, for your son, I think it's critical to list only the food proteins, walnut and hazelnut, for example, in your case. Those should be listed as their actual allergens. Everything else that they're eating or everything else that our provider team is relaying to you that is safe, those should not be listed on there because, again, they are in a state of tolerance or potentially in a state of remission, depending on where their values are at. So long story short is anything that's an active treatment, meaning things that are daily, things that are given under treatment dosing parameters, those things should be listed on any of these forms as risk. Anything that's done on a weekly basis or even less than that, those can be not listed at all because your child can freely eat them, and that's a great thing.
Hi, Dr. Randhawa. My name is Anam, and we are from Chicago, Illinois. My son has been in the program since October of 2019. So thank you for everything you've done for us so far. We are still quite a ways from remission, which is fine. So I know Musa is going to be in elementary for a couple more years, hopefully before we reach food freedom. As he was remote this past year, the teachers would ask, what did you have for breakfast? And he would say, I had egg, hash brown milk, and nuts. And they would say, wow. But then on the flip side, I came in at the end of the year, with getting a 504 plan for him and mentioning all those things that he's allergic to and more. And you mentioned that the TIP plan is far too complex for them to understand. So I get not explaining all of that to them, but also making sure that they completely understand how dangerous these foods still are, even though he has them at home. Do you recommend printing out kind of the anaphylaxis symptoms chart that you posted earlier in this meeting and maybe telling them specifically how Musa would react or what reactions they should look for? And also, as far as the scenario kit, you mentioned a liquid-based steroid A parent just asked that. They don't need the scenario kit, but a liquid-based steroid would be good. Is that something that we can contact Tip Help about and get that for the schools? Thank you.
Yeah, thank you. Great set of questions. I would say as far as the questions about what should be listed and risk of symptoms, I think you're bringing up a very good point. There is what is on a list, and then there's what you're clinically seeing. So for example, if a child is having an anaphylactic reaction to a food that has not been treated yet, especially with a long list of potential allergens, is a teacher really going to look at that and designate effectively? And so what I try to educate teachers and school nurses about is look at them as two separate things. If you see a child who's acutely having an anaphylactic reaction, treat it, don't ask too many questions, right? You know you're having an at-risk situation, deploy the epi, call for help, pull up your actual anaphylaxis plan sheet, see if there's any additional medications available, stabilize the child first, then try to assess. What I generally talk about are the other aspects, like let's say a child presents and their lip is slightly swollen. Again, they should be able to assess, is their airway safe? Are they otherwise awake, alert, and doing well? Then have them sit down, pull out their sheet, let's look at the list of foods, and let's identify what the potential cause was. And that level of calm is something I've unfortunately not seen all too often in school systems. But I have seen that when parents go educate schools and give them this type of information, it is exceedingly helpful. So basically, the answer to your question is they should actually list all those foods, and they should abide by the 504 plan. And again, if you need our help with that, we're more than happy to advocate on your behalf. Until your child is in frank remission, if you want to be more conservative on that aspect, and make sure that all those things are avoided, I think that's not necessarily a bad thing. But it's something that we have to actually be a part of that discussion. So please let us know. We'll be happy to help you out.
So our question is, if our son can't finish his maintenance foods in the morning, can we pack the rest of the maintenance foods for lunch? And if we can pack them, should someone from the school supervise our son?
Thank you. The question, just to restate it, is if a child has maintenance foods, which we know we try to dose those in the morning. If they can't finish those foods in the morning, can they be given to complete at school? Again, a maintenance food is clear. It is uncapped. It doesn't have restrictions. Those types of foods certainly could be handed off to a trusted individual at the school system. The question is, do you have those folks at school who can actually make sure it happens? If you do, we've certainly seen that happen, particularly in younger children who are in preschool or pre-K. Often is the case that the individuals at the school will actually administer some of those foods. We do this all the time at summer camps, things of that nature as well. So absolutely, it's a reasonable thing to do for those particular foods.
Hi, Dr. R. Nice to see you. My name is Jamie. We have been in the program for about 4 years. I have had one graduate, one very, very close to graduating. So that's kind of my question. It leads into graduation. Obviously, our maintenance has changed over time and adjusts depending on, I guess, the time. But I'm looking kind of forward to the future as far as maybe college. What is their maintenance going to look like at that point for school?
Thank you, Jamie. Good to see you as well. I think when people hear you've been in the program 4 years, they're thinking that this is a long time. Remember that the process of therapy, has large gaps, especially between tolerance visit 1 and 2, where really most food maintenance is on a weekly basis, and then you're just working on one primary food to hit remission. But to answer your question, I think it's a great question, is most kids years later are on 2, 3, or 4 week cycles. I'll just throw this out there, and it may be too much information, but once you hit remission, there are 2 additional steps. There's a step of immunological status that we call peripheral tolerance, followed by central tolerance. Peripheral tolerance means that we measure your immune system activity in the blood, and we do this via some specific mechanisms, cytokine analysis and so forth, to know that your system is adapting in a way that we don't have to expose the lining of the gut on a regular basis. And then there's central tolerance, which really means that your bone marrow is starting to change in a healthy way. And so cells, particularly stem cells, are no longer producing some of these aberrant antibodies that cause anaphylaxis. So we're knowing now over more and more years that children hit those phases at about 2-3 years out, 4 or 5 years out. And at those stages, we're able to drop these kids down to 2-week, 4 and 3-week and 4-week cycles. So for your 2 girls, I'd imagine that they're going to end up in college and they'll probably be on once-a-month cycles. And frankly, they'll probably be eating all these foods anyway, and their numbers will zero out, and life becomes much easier. Thank you.
Hi, Dr. R. I'm Liz from Northern California, and my son is 5. And just to reassure anyone that's not, he's been in the program for about a year now and is already getting into the close to tolerance range. So obviously different for everyone. I can't look at you without thank you. So I'm going to do that, and then I'll get on to my question. So thank you. So my question is really just best practices. I think you've provided really good, like what information we need to give specifically to the teachers, but with them worried about COVID, worried about everything else starting this year. I'm having a hard time wrapping my head about how to do that. Like, so how often do I need to be bugging them? Like, what are some best practices that you've seen actually working? And then I'm especially worried about them being able to identify the symptoms of a reaction, because in particular, my son has typically not have the typical, full on body hives when he has had previous reactions. So my son, for reference, is going into kindergarten, but I know everyone's kind of got varying levels of ages. So maybe best practices on how to talk to teachers throughout the years.
I would say, the best thing that I've noticed when you're dealing with this situation, and again, I've had some experience in helping schools out even with coronavirus. So I do get a sense of where their pain points are. And, again, with vaccination rates high, with a lot of the masking systems, the teachers are coming back into the school year, and they are kind of getting back into a normal state of balance. I'd say to answer this question in 2 different ways. First, in any sort of extracurricular activities, I would be much more worried about those right now. Soccer, softball, baseball, etc. Those kinds of sports, the teachers are less worried about COVID. And because all the kids are kind of coming back in a swarm, I feel like there's a lot more errors happening. And again, I just presented this recently with actually some other specialists. And it's interesting how the number of orthopedic fractures have skyrocketed in the last couple of weeks, because all these kids are just coming back and everything's a rush and nothing's being planned the same way. So those areas I'd be more concerned about. Schools, though, have had the time to kind of really, I'd say organize how they're going to reopen. They are limiting certain activities, and they are limiting food-based activities as well. So the first thing I would do is go to the school and say, what is your COVID-based practice for lunch and for snack? And then piggyback your requests on those things. I found that to be very successful. So if you can at least identify what their plan is, what that strategy looks like, and then say, look, here's my child's particular case. Let's have a conversation about that. I acknowledge your new system. I want you to acknowledge my child's case. And all too often you have a really, really good outcome. So that is our last question. I want to thank everybody for coming on with the video series this time. I find it much more interesting when I'm not the only person talking. So I wanted to thank everybody who joined us today. We will be answering any remaining questions via email. So whatever you send in, I promise you we'll get back to you. For all the parents who are in our program, by all means, use Tip Help. You guys all know your pod leads. You know your providers. We're here to help. We'll do anything possible, make sure that your child gets back to school safely. We will be having another live stream broadcast like this on the 24th for anyone who's missed. And again, we would like to open this to the general community of food allergy parents as well. So by all means, let them know. And hopefully everyone has found this useful. I wish every parent and child who is in our program, obviously the best. I also wish you a good opportunity to get back into school. Remember, take it slow. Kids have not been in school for a while. You can't expect things to just click like that. Take the first few weeks to adapt nice and easy, and we'll go from there. Lastly, just like everything else with this pandemic, please get vaccinated. It's really important. We've got to get past this. Better options will come as months go by. So, as you try to decide on what your next steps look like, pay the greatest attention to not transmitting. We want to be in a position where we're not transmitting any of this moving forward. So with that said, I wish you all well. And until I see you again next time, take care.